can refer back to some of the things that we spoke about. I will be moving along the slides as I lecture, but I'm not going to lecture slide by slide. Early on, I probably will, but as we start to get into it, especially with the lab parts, we won't. But the information is on the slides to help you for study purposes. Okay? So every year, if I put less information on the slides, then the reviews come back, I want more information on the slides. I put more information on the slides and say, too much information on the slides, I want less. So I'm going for the perfect happy medium. You can let me know if I finally achieve that perfect happy medium. All right, so let's get going. So the first question that I always like to pose, considering this is basically a therapeutic exercise class, is what do you think of when you think of therapeutic exercise? What does therapeutic exercise mean to you? What's that?
I said first we got to break down therapeutic.
Oh, going even deeper. All right, so how are we going to break down therapeutic?
Therapy. So what is like a therapy? Because it's, I
Where
guess.
does T come from?
I'm saying, I guess, more in the sense of like, in my head, the first thing I go to is, okay, well, it's obviously different than exercise.
Yeah.
You know, so then why is the therapy important to add to that? I guess is what.
Are you going to answer all my questions with a question?
No.
So that is the second question. So just from a definition standpoint, if someone says define therapeutic exercise, how would you define it? Without looking at the definition. Yeah. Exercise to help improve function. Does that work? You like that? What's that? That was a good answer. So how can exercise help improve function?
Improve mobility.
Improve mobility. How else can exercise help improve function?
Improve movement patterns.
Improve movement patterns. So we have mobility, movement patterns. What else?
Strengthen weak muscles.
Strengthen weak muscles. Create what? Create proper rhythm. Reinforce stability. Great. You got almost the whole list.
Optimal joint congruency.
Optimal joint congruency. So I think some people are right ahead here. So what makes therapeutic exercise different than just going to the gym and saying, oh look, there are those 4 Nautilus machines and those free weights, I'm going to just go do a nice fun workout?
Does it like just target a certain dysfunction?
It targets a certain dysfunction. The difference between therapeutic exercise and a regular exercise routine is how it's targeted. Now you can go into a workout, you can work with a trainer, you can work out with a Pilates instructor, and you can have targeted exercise. My goal is to tone up. I want to work all the beach muscles, right? So you can have a certain goal, but from a therapeutic standpoint, we want to target what the biggest limitation is. So going back to the original definition, if someone can't perform a certain function, we want to say we want to do an intervention to help them to be able to better perform that function. So we need to define what is the limitation. Is it poor congruency of the joints? Is it poor timing or movement pattern? Is it atrophy? Is it weakness? When is it a lack of stability? If we define it, then we say this is the impairment that's limiting their function. We will now pick an intervention, a therapeutic exercise, to improve that, which will ultimately help to improve their function. And that's why I say this class is a differential diagnosis class, because you're going to break down movements, you're going to break down movement patterns, you're going to challenge the body from a strength perspective, from a motor control perspective, from a stability perspective, and try and figure out where is their greatest limitation. Okay. And that's exactly where the definition is. It's systematic, it's controlled, it's planned, it's targeted. It's aimed at improving function because it's aimed at trying to improve whatever limitations are. So what's an example of a therapeutic exercise? What's that? Calf stretch. Stretching. It's a therapeutic intervention. What else?
Hip abduction.
Hip abduction.
Balancing, so like on an Air X.
Balance exercises on an Air X.
Isometric holds?
Isometric holds. How do we categorize isometric holds and hip abduction? A strengthening exercise. What else?
Eccentric control.
Eccentric control, breaking that movement down further. Stairs. Now stairs is a function.
Well, like going up and down stairs to like improve being at home and like doing something that's clean.
So endurance.
So
Like movement.
what would make stairs an exercise versus just a function? Focusing on the form, where the knee goes, and the timing of it, and how much they do it. So it could be, as you said, it could be a functional exercise. It could just be the function, I need to walk stairs. So go do more of that. That might or might not be appropriate. But if we adjust the exercise, we can turn it into a functional exercise, and we'll bring them to the level of challenge, whether it's fatigue or pattern challenge. We can take that function and turn it into an exercise. So absolutely. What else? We have strengthening, we have balance training on an AirX, we have functional exercises such as stairs, neuromuscular re-education, saying some of my favorite terms. So some kind of movement training.
Do like breathing exercises and
Breathing exercises, absolutely. What about Pilates? What about yoga?
Yeah, I would think like endurance related.
So what would make Pilates or yoga a therapeutic exercise? Well, either could be for stability, they could also be for mobility.
Yeah, flexibility, strength. Did you say flexibility? No, it's different than mobility.
Well, there's a subtle difference, we'll talk about that. Yep. But what makes it different if someone goes to a general yoga class versus a therapeutic yoga class versus a therapist who applies yoga techniques in their treatment?
Does it have something to do with increasing the intensity?
It may. So why would increasing the intensity make it therapeutic?
Because you're kind of challenging the patient and making them like break the comfort level.
Yeah. You're challenging the patient to the certain level to help them elevate to the next level.
I was gonna say that it's targeted towards their impairment.
Exactly. It's targeted towards their impairment. So anything that you could list, this list could go on forever. Swimming, pool exercises, aerobics, yoga, Pilates, gyrotonics, anything can be a therapeutic exercise if it's targeted towards their impairment. So targeted towards their impairment to say, I am now utilizing this yoga posture to help this person's stability. So you have to make sure that while they're performing that exercise, you're pushing them to their comfort level. You're pushing them to the limit so they are hitting fatigue because your goal is stability. If your goal is mobility or flexibility, then you want to push them to their range of motion. So in other words, you want to take whatever exercise, whatever tool you have in your toolbox, apply it, but dose it the right way. Structure that exercise to target their impairment and make sure that they're doing it at the appropriate level that helps to improve their impairment. Okay? So the list for therapeutic exercise just goes on and on. It goes way even beyond this. But it's task specific and it's goal oriented. What you'll see throughout the program and the big shift in the field is this idea of a patient-centered approach. And the reason for this is it's targeted. And what we are going to do is we are going to focus on movement. But the reason I put these slides early on is it's only one slice of the pie. Essentially, the patient is in the center, and in order for them to function, they have many needs. Their metabolism can affect it, their psyche can affect them, their movement control can affect them, and any pathology that might be going on can affect them. So what we want to do is figure out what's the clinical priority. Which slice of the pie is largest that we need to zoom in and address to try and help to change their function. So in this class, our assumption is the largest slice of the pie is the mechanics. It's the movement. And we're going to zoom in and start to address their movement. And we'll break that down even further, because when we say movement, that includes motor control, stability, flexibility, and strength. But we are not going to consider the pathology in this class. We're always going to keep it in mind. And we'll talk about there are certain exercises you can do specific to the pathology. But we're going to really look at movement. In your MS classes, you're going to focus on the pathology, the pathoanatomy, what can be going on here, and what sort of techniques can we do to try and facilitate healing, create the environment for healing. And obviously, they'll both pair. Your patient, at one point might have the largest slice of their pie be the pathology. So if someone has a fractured femur, I'm not going to put them on the squat machine and make them work at 80% of their 1 rep max, unless I don't want to work anymore. But, so this largest slice of the pie is their pathology. Create the environment for healing, help that come along. Once they go through that process, they're left with atrophy. Now they have quad atrophy. Now it is appropriate to target the movement. In other words, try and hypertrophy the quads. Put them on that squat machine and help them work at 80% of their 1 rep max so that they can start the bulk up. So we want to think about the patient in the center. The thing that you want to keep in mind is we're going to dive deep into the differential of movement. But when your patient comes in fresh off of a rotator cuff repair, and you say, well, my differential is clearly that supraspinatus is atrophied. So I need to work that supraspinatus to the point that that muscle hypertrophies. And they are 2 weeks out of surgery. Hypertrophying that supraspinatus is not the clinical priority. So although we will dive deep into trying to figure out what their main movement priority is, we want to keep in mind that the patient's in the center and look at the whole picture.
Could you maybe give an example between, like, just so we, like, the class knows, like, what's the difference between assessing the movement and then giving a therapeutic exercise, and then, like, I know in MS, like, we'll be doing doing it differently. Could you just, like, give an example of both?
Well, the whole
Like the
class
path-
is
no,
an
no, no.
example of both.
I just mean, like, you were saying, like, there's a pathology,
Mhm.
and you're doing it that way. Could you just, like, do, and this class was just assessing the movement. Is there, like, an example, just so, like, I don't get confused?
Sure. All right, well, come on up. Want to jump right ahead? This is just the intro. We were going to get into all that.
red, sorry guys.
So, it's okay. So let's say we're coming in, we're assessing the shoulder, and we hold the arm up, hold the arm here. Now don't let me push you down and let your arm drop. Okay? So I'm going to cue her. So ignore me for a moment. What I want you to do is drop your arm when I push.
Okay.
So I'm going to say, okay, we're going to do a little strength testing. What I want you to do is hold your arm up here and hold this as hard as you can. Ooh, there's a drop. Okay? Right away, that's an indication that I'm starting to wonder, is this more of a pathoanatomical issue? Right? Because there was a certain finding. We saw a drop arm sign. So from a pathoanatomical perspective, I can do certain assessments. I can do certain special tests to try and determine if a structure is injured. I can do selective tissue tension testing. Now that I'm different muscle, but raise the arm above your head. Do overpressure. Now don't let me push you anymore. Does that bother you? Hold, 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 hold. Does that bother you? So I am putting on the hat of differential diagnosis from an anatomical perspective. Okay? I'm using that selective tissue tension test to determine, is the structure painful? I palpate it. Is the structure tender to the touch? I apply a special test. Is that test positive, which increases the likelihood that there's a pathology going on? That would be how I would do my anatomical assessment. From there, I would say it seems like there's a tendinopathy going on, or it seems like there is an irritated impingement. We're going to apply modalities, we're going to treat the pathology, and let it calm down so that now we can come back and do it from a movement perspective. Okay? Now, for your second example, hold your arm up there. Now, just hold it, but like, be weak. Okay? So I want you to hold the arm as strong as you can. Okay? Hold, hold, hold. It seems like that's weak. But there was no drop arm, and it wasn't painful. So now I put on my mechanical hat, and I want to try and figure out what's going on. Is that weakness because the scap gave? Is that weakness because you had poor rotator cuff control? Or is it due to rotator cuff atrophy? So now I'll come in and I'll say, okay, hold your arm up there. I want to do this again. I'm going to come in, I'm going to stabilize the scap here. All right, now hold again. Now be strong. Hold. Oh, that's very interesting. I just stabilized your scapula and all of a sudden the arm was stronger. So that gives me some good information about where I'm going to go next. And now I'm going to investigate the scap further. Okay? All right. Yes, sir? That's basically a quick overview of how we're going to approach every area of the body. We will do a movement assessment, and if there's pattern recognition for a pathology from the MS classes, you'll see the pathway and the algorithm that you'll go through in order to try and differentially diagnose that. If you feel confident that the pathology is stable and you want to actually assess their movement pattern, from this class we're going to look at different movement ways to do that, similar to what we just did here. Okay?